Thank you so much for having me. It's a pleasure to be here. So the focus of this presentation will be radio frequency microneedling. I'm sure many of you have already started using these devices, but some may not be aware of all that has been published about this topic. So whether it's related to skin rejuvenation, acne scars, cellulite, stretch marks. So I'm going to be showing you this during this presentation, and I hope you find it useful. So nowadays, many patients are interested in anti-aging, and many of them are looking for non-invasive or minimally invasive procedures with minimal to no downtime. Radiofrequency has been used in cosmetic derm since the early 2000s, and it uses the energy generated by electrodes to heat the dermis and stimulate collagen production. So once the current reaches the tissues, it will meet the resistance of the tissue, that is called impedance, and then the electric energy will be converted into thermal energy, and this energy can be calculated using this formula, where I is the current, Z is the impedance, and T is the time. So the impedance or the resistance of each tissue is different, and it can vary according to different factors, among them the skin hydration, the electrolyte composition, the collagen content, as well as the temperature. So we have different types of radiofrequency depending on the electrodes. With the monopolar type, there's one electrode and there's a grounding plate, and basically the radiofrequency can reach from the electrode to the grounding plate, so it can reach deeply, versus with the bipolar radiofrequency, the current is emitted between the two electrodes that are placed on the skin. And it's estimated that the depth of penetration is around half of the distance between the two electrodes. So while monopolar radiofrequency can reach deeper, bipolar radiofrequency is generally less painful, and basically the distribution of energy is more controlled. The newer generation of radiofrequency is the fractional radiofrequency, and I'll be talking about this in a second. So Thermage is an example of the monopolar type. It was the first FDA-approved radiofrequency device for wrinkles on the upper face in 2002 and the entire face in 2004. As we said, the problem with bipolar radiofrequency is the depth of penetration, but there are ways to increase this depth. There are two technologies that can be used. The first one is the electro-optical synergy, or ELOS technology, where we can use, for example, IPL or diode to heat the tissues. This would raise the temperature and lower the impedance, so the depth would be higher. We can also use phases technology, or functional aspiration controlled electrothermal stimulation, where we use a vacuum-assisted handpiece to also increase this depth. An example that uses both technologies is Vela Smooth, where we have the bipolar radiofrequency as well as the infrared light and the suction system, all of this to improve penetration. So fractional RF is the newer generation. With fractional RF, the needles can be insulated, meaning that there's a coating material all over the needle except for the most distal part. And we have the uninsulated needles, which are not coated. With the uninsulated needles, with the monopolar and with the bipolar radiofrequency, we must cool the epidermis to prevent an epidermal burn. We have to maintain the skin surface to temperatures below 42 to 45 degrees because the threshold for an epidermal burn is around 44 degrees. So we have to use, for example, a cryogen spray, or of course we have to keep moving the handpiece. There is some benefit to heating the dermis from 45 to 60 degrees because we do get partial collagen denaturation. However, studies have shown that the optimal results, we get them when the dermis is heated from 65 to 70 degrees. This is when you get increased cellularity, which can last for 10 weeks and even longer. So the advantage of the insulated needles is that it allows us to reach this critical temperature without burning the epidermis. Here we can see a column of collagen denaturation with RF, and the immediate effect of heating is the collagen thickening and contraction, and then with time we will get new collagen production. As you can see, the epidermal injury is limited to the same we see with regular microneedling, so it's just mechanical trauma that will usually heal within 24 hours. So besides the type of needles that can be used, there are other variables or variations when it comes to the different machines. We could have variable or fixed length needles. We could have manual versus mechanical insertion. With the manual insertion, the operator has to press to get the needles in. Of course, a problem with this is that you can get operator fatigue. Some devices offer temperature or impedance feedback, and this is very important. So this is a table that summarizes many of the devices that are present with their characteristics. So for example, if we look at Secret, it offers insulated and non-insulated tips. The Genius from Lutronic offers impedance feedback to optimize the energy with fewer side effects. The Morpheus 8 of InMode is able to destroy the fat with up to 8 millimeter depth of penetration. There are certain contraindications when it comes to using radiofrequency. For example, implantable medical devices, collagen vascular diseases, autoimmune conditions, and of course, caution is required in patients who are under radioactive treatment or who have recurrent herpes infection. This is a more extensive list from the Morpheus learning platform. If you want to take a picture, I will not go over it. So when I did my training in microneedling RF, the trainer said that it's better to avoid it in patients who are taking oral isotretinoin. But I did find one study where basically patients in group A were taking isotretinoin, 0.5 milligrams per kilo per day, and microneedling RF was done. The total number of patients who were taking the Accutane were 12. They did 4 sessions of MRF, and none of the patients developed delayed healing or keloids or hypertrophic scars. Of course, one study isn't enough, and we need more studies with more patients to confirm the safety. So RF versus laser, what's the difference? Whereas the RF relies on electrothermal energy, the laser relies on photothermal energy. The RF is chromophore independent, so it's applicable to all skin types. However, it's definitely not without risks. And the advantage of RF is that it offers little to no downtime. So this was a study that compared ablative fractional erbium YAG versus microneedling radiofrequency for facial atrophic acne scars. They used the Photona XS Dynamis, and these are the settings here, and compared it to the Vivacy from Korea. 4 sessions were performed, and there were marked improvements after both treatments, whether it's on visual assessment or with OCT, which showed increased epidermal and dermal thickness, and there were no significant differences between both treatments. Pain was more intense with the microneedling RF during the session. However, when the patients went home, pain lasted more in the laser group compared to the microneedling RF group. This is another study comparing non-ablative fractional erbium glass to microneedling RF, and both treatments resulted in improvement. It was a bit better in the laser group, however, it wasn't statistically significant. This is a third study where they assessed ablative laser, compared it with scarlet RF, this time for face and neck wrinkles. What's interesting is that laser was more effective for periorbital wrinkles, whereas MRF was more effective for nasolabial, perioral, jawline, and neck wrinkles. And the authors believed it's because the laser causes broader, more superficial microthermal zones of injury for the upper face with the thinner skin, versus the MRF, which creates deeper MTZs for the lower face with thicker skin. So the primary complaint when it comes to microneedling RF is the pain during the session. At Skin Experts Polyclinic, we use a good topical anesthesia for 40 minutes. We also use cool air. We also use talk anesthesia, where you basically talk to the patient throughout the procedure. We have nice music playing. We do have a great French playlist. So this study reviewed the high-quality evidence available for MRF, and based on the high-quality evidence, they made treatment recommendations for each of the skin concerns. First, they identified 246 studies, but then after filtering out all the studies, only 42 studies remained. And I was honestly surprised, because when I was doing my search, I thought I would find so many studies about MRF, but there are studies, but it wasn't as many as I expected. So here are all the skin concerns summarized. We'll go over them one by one briefly. So skin rejuvenation had the highest number of studies, 14 studies total, with 4 high-quality studies. For example, here they assessed periorbital wrinkles after 3 sessions via visual assessment, but also imaging. They used 2 needle lengths, the short microneedles with 0.8 millimeters of penetration and the long ones with 1.5 millimeters. Both groups showed improvement. However, the 1.5 millimeter was more effective compared to the 0.8. In this other study, what's interesting is that they found that higher temperatures, meaning 70 degrees, longer treatment duration, and larger volume of fully denatured collagen per insertion correlated with less improvement in wrinkles compared to lower temperatures of 67 a shorter duration, and a smaller volume of denatured collagen. And the hypothesis of the authors is that if a thermally induced dermal lesion exceeds a certain threshold of size, such that hypoxia occurs centrally to the lesion, this would be counterproductive to the induction of wound healing and correlate with less clinical efficacy. When it comes to acne scars, I already showed you a few studies comparing it to the laser. Of course, as expected, boxcar scars and rolling scars tended to show the greatest response compared to ice pick scars. I was surprised to find out that there are 5 high-quality studies that show the benefit of MRF in acne. This study actually compared microneedling RF to regular microneedling, and while the MRF showed improvement, the regular microneedling showed worsening of acne. And I do see this in the clinic. When I started doing microneedling, I was doing it in patients with active acne, and their acne always worsened. So I never use microneedling now in patients who have active acne. I also tend not to use MRF, but after doing this presentation, I might try it. When it comes to axillary hyperhidrosis, it's believed that MRF can destroy eccrine sweat glands, and that's why some studies have shown efficacy. In these 2 studies involving 50 patients, there was a 42 to 46% improvement after 3 sessions, and 28% of the improvement was retained 1 year after the sessions. This study compared Botox done to one underarm to MRF done to the other underarm. And of course, as expected, Botox was more effective. However, both treatments led to improvement. When it comes to stretch marks, there is only 1 high-quality study, but 5 studies in total. In this study, they did MRF to the right side and laser to the left side. And they found that both treatments were effective with no difference between both treatments, and this was confirmed with the Visia 3D imaging and also with dermoscopy, which showed that the lesions were less wide. When it comes to androgenetic alopecia, we know from studies with regular microneedling that wounding can stimulate hair follicle growth. There's only 1 study, and here they used, on one side, they told the patients to use minoxidil BID, and on the other side, they also used minoxidil BID, but also did 5 sessions of microneedling RF, and on the days when the MRF was done, the minoxidil was applied directly after the session to enhance the penetration, and they found that compared with the monotherapy, the combined therapy had a higher degree of improvement when it comes to both the hair count and the hair thickness. For rosacea, there was a study that showed improvement, and the authors hypothesized that it's due to the anti-inflammatory, anti-angiogenic, and antimicrobial effect of the MRF-induced dermal remodeling. Here, 2 sessions were done and resulted in a 20% mean improvement. It was slightly more effective in patients with the papulopustular rosacea compared to the erythematotelangiectatic rosacea. And there was a reduction in the number of mast cells, but also in the different markers for angiogenesis, for neuroimmunity, and for innate immunity. Cellulite, I was surprised there was only 1 low-quality study. They did only 1 session, and 86% of the participants had improvement. And finally, for melasma, 2 studies evaluated MRF as an addition to the Q-switched Nd:YAG, and the combination led to a more significant improvement, but also a reduced risk of rebound hyperpigmentation once the treatment was discontinued. So just a few recommendations post-procedure. Avoid all makeup applications until the following day. Apply, of course, the soothing creams. I tell them to avoid sun exposure for 2 weeks. Here it says no restriction when it comes to exercise, but I prefer for them to avoid for 24 hours. I don't want the sweat to irritate the skin. They can use multiple pillows to elevate the head, and of course they have to use a gentle cleanser. Now, these are some of the complications that can occur after treatment. Superficial infection and acne flare can occur, especially if the skin wasn't properly cleaned. You can use clindamycin ointment. Activation of herpes can also occur. Of course, we recommend prophylactic acyclovir in patients with recurrent herpes. Persistent grid marks can also occur, and if they do occur, you have to use lower energy in subsequent treatments. Redness and edema, post-inflammatory hyperpigmentation, as well as post-procedure bumps, which can be managed by the Kligman formula or maybe the thiamidol. So here, this is one of my patients. I did MRF 1 session. It was an average setting. I wasn't too aggressive. She was doing great, and then suddenly on day 3, the redness started to increase again, as she also developed a bit of facial edema. I spoke to the trainer. I was using Morpheus, and they recommended Fusicord 3 times per day, as well as oral antihistamines. She was improving, and then 3 weeks later, the redness would come back. I also did several soothing treatments for her. We did several sessions of LED light therapy. We did laser genesis, skin boosters, and she would improve, but then the redness would appear again. And you can see 2 months later, we can see the needle penetration marks, or the grid marks, as if the session was done 1 day prior. It was really very unusual, but this can happen. I saw the patient 1 month ago. She came in for Botox. Thankfully, she still came to me. And she told me that it took a good 9 to 10 months for the redness to completely go away. So what is it exactly? Is it a hypersensitivity reaction? We don't know exactly. I found one study that reported prolonged inflammatory reaction. And there were 2 cases. They were successfully managed with a 585 pulse dye laser. And in the study investigating in vivo histologic response to the microneedling RF, usually the lymphocytic infiltration persisted for up to 1 month, but in these cases, it persisted for a long period of time, over a year. I don't know if any of you have had such cases. If you did, please share it with us. Thank you very much.